So what this is 10 years ago in 2013, I started a study called the Modifiable Variables in Parkinson's. And every 6 months for the last 10 years, I have been sending you all out surveys. And as my kind of thank you to all of you who have participated, 3,500 of you received an email at the end of last year saying, "Hey, I just want to say thank you for participating and let you see what we're doing with your data and what we are learning from you." And so today's class is my attempt at going through what we are learning here. So the first thing that I want to say is that it has been very, very, very difficult to recruit. I would like to think that I have a pretty exciting study, that me asking you all to volunteer 3 to 4 hours a year is not that big of an ask. People don't need to leave their house. They don't need to leave their city. They don't need to go anywhere. They don't need a biopsy. They don't need a stool test. They don't need an exam. We are just asking for about 90 minutes of survey questions twice a year. And of the 10 million people living with Parkinson's right now, I am begging and scrambling to get 200 people enrolled per year. It is absolutely shocking to me how motivated this crowd is, how enthusiastic all of you are, the support that I have received. And even with all the work that I have done and all the support I have received from all of you, it is like hitting my head up against a wall to try and get people to enroll. The more people who enroll, the more valuable this data is. And it has been the hardest part of my job, getting people to enroll and stay enrolled. Sorry about some of these edits over here I missed. So what we see is that lots and lots and lots of people enroll and participate once. We have about 600 people who have completed the survey 3 times. We have about 200 people who have completed it as much as 8 times. We have one person, I need to find them and send them a bouquet of roses or something, who has participated 18 times over the last 10 years. So there are people who are getting the email. It's not being sent to spam, that are consistently participating. Thank you, thank you, thank you. Um, and part of my goal in putting this whole thing together was to let you know, like, we need you. Like, thank you for all of you who have participated once, but we're just getting started, and I don't want you to peter out here. I need you to stay enthusiastic and stay enrolled. It's fine if you miss one or two of these along the way, but pick it back up 3 years later. That's fine if there are gaps. It's just we really, really benefit from your sustained participation. You can see we used to not ask about prodromal people were not enrolled in the study for a long time. We have now started, it tells us here that there are 10 people with no diagnosis of Parkinson's who have answered the survey response once. Um, 1,400 people, 1,469 people have answered the survey 3 times. One person with prodromal Parkinson's has given us 3 survey responses. So this part is pretty exciting. The number of people participating is growing. Parkinson's is growing. I worked really hard to get the IRB ethics board to let me not just study people with Parkinson's, but people with other related Parkinsonian disorders. So think of your spouses, think of your best friends, think of your kids. If you know anybody who has any of these things, a positive biopsy or Parkinson's gene, the dogs told you smelled like Parkinson's, you act out your dreams, you have a low heart rate variability on your Apple Watch or Oura Ring, you've lost your sense of smell, you have an abnormal DAT scan, you have irritable bowel syndrome, ulcerative colitis, Crohn's disease, or inflammatory bowel disease, or any type of chronic constipation, we need your participation. And a lot of you have kids and spouses and best friends with IBS. A lot of you have a friend who has a bad sense of smell or acts out their dreams. Those are people we are trying to capture here. And it is really exciting. I mean, I will say, I think we are one of the first, probably 4 or 5 studies, maybe even the first, to get IRB permission to start to follow a prodromal cohort over time. This study has not become popular yet amongst the prodromal people, but I'm hoping it will be. Everybody who gets a positive DAT scan or a positive skin biopsy, but doesn't quite meet the criteria for Parkinson's disease yet, this is a great place for them to feel like there's something they can do. Um, we have more men than women get Parkinson's disease. What has been interesting is we pulled these data we've previously published in the past, and when we've published in the past, there were more women in our study than men. And we must have just taken one of the samples during 1 year that was true. But over time, it really does look like this study has more men participating in it than women. Parkinson's is a predominantly male disease. And so I feel more confident now that the people in this study are a true and accurate reflection of the Parkinson's population. You can see the average person is not too far into Parkinson's, diagnosed about 5 years ago. Their average pro-PD score, you can see the people who don't have idiopathic Parkinson's disease have are more symptomatic than people with Parkinson's disease. This is why when we do research, we have to kind of tease out Parkinson's people from some of these other conditions, because we have different rates of progression underlying them all. And again, it is so frustrating. If I had MSA, PSP, dementia with Lewy bodies, cortical basal degeneration, if I had one of these forms of Parkinson's, I would feel so ignored. You all with Parkinson's know how inadequate the body of research is that exists. I can't even imagine if you had one of these more rare diseases that nobody is giving attention to. So for your friends or people you may know who have other forms, please tell them I do care about them. We are trying to capture data on them. We are trying to learn from them. We want to know if they eat their vegetables, will this fare better also? We just, so few people with those conditions are participating in the study that we haven't been able to answer those questions. So this is just the breakdown of different stages of disease. You know, you can see that people with dementia with Lewy bodies are having more severe symptoms. We're not catching those people in the early stages. By the time they're joining the study, they're a little bit later
You have a
in.
chair? Ron, where are you gonna
Oops,
be?
oops. Sue, can you mute you? I can't. Um, okay. So here is, I don't know why all this is showing up on the sides, my apologies. So what this shows is how long has it been since people have been having symptoms and how long has it been since they've been diagnosed. And obviously you would expect people have symptoms for a few years longer before they get diagnosed. You know, 10 years ago, 100 people were having symptoms, but only 50 people had been diagnosed. So there's a delay, and that's kind of what we're looking at here. What I want you to see is the scarcity of, don't all of you want to know a little bit of heads up about what's happening down the road? Hey, I know how I'm doing today. I'm worried about myself in 10 years, 20 years, 30 years. What is that going to look like? And right now, I am really confident about being able to talk to you about what the first 10 years after diagnosis looks like. We have so few people who were diagnosed 20 years ago, 30 years ago, enrolled in this study, that it's hard for me to give you the information that you want. It's not that these people don't exist. It's just we haven't managed to find a way to recruit them into this study. So age, this is about normal. Most of the folks in the study are about 65 years of age, and that fans outward. Income categories, this is the people, 3,500 people in this study. This is one of the problems we run into when we have self-selection bias in research. We're going to talk about the Swedish study in a minute, where they go through the population and they don't discriminate. In my research, it is very biased, right? We ask who wants to participate in a study on modifiable variables. That appeals to a certain type of person. People who are interested in this tend to be above average intelligence. People who are above average intelligence tend to make a little bit more money. Pretty soon, we are now studying people who have access to movement disorder specialists and fancier drugs and have gym memberships and things like that. So, one of the real problems that is pervasive in all of research is that richer people participate in research, and it's really hard to know whether or not those findings transfer to the whole population. So, it's skewed data. I mean, I wish everybody in the study were in the 150 and higher income category, would make the world a better place. But I just want you to see that this in the real world is probably more of a bell curve where income starts going down, but that's not what we see on our end. We see that the people who participate in research tend to make more money. As you can see, this is ridiculous amount of higher education with people making, most of our study participants have professional and graduate degrees. This is a very, very highly educated cohort. Way too many. I mean, I don't want to say too many white people. I don't mean it like that, but not enough of anybody else from a demographics perspective. This is so not fair to the rest of the world. I mean, there are a whole bunch of reasons throughout history why some of these minority groups have been burned by research and are less than enthusiastic about participating in research. I mean, there are some real horrible things that have happened with research participation in minorities in throughout history. And now we're in this terrible situation where we are having a really, really difficult time getting underrepresented groups to participate. So everything that I'm about to say today is really, truly applicable to Caucasian people. I wish I could tell you it was applicable to everybody else. We just don't know because we can't find those people to participate in the research. Most people are partnered and married. That was surprising to me. I mean, I thought most people would be married. I didn't realize it would be that skewed. But less than 500 people out of 3,500 are single. That was a little surprising. I'm super proud of how far reaching these surveys are. And I think no one will be surprised to see that the people who are most likely to participate in an English survey are countries that have English as their primary language, right? United States, Canada, Australia, and United Kingdom is where we have the most survey responses. But it is really, really fun to see that there are patients participating from all over the world, and it does give me hope that we can reach further. When I was asking about limited resources here, what I was asking is, we have limited resources, and I'm curious, do you think it's more important, we can discuss this later, that I just take what I have and keep going deeper? Like, hey, like with this, we have a cohort, we have a population who's participating. Do we take our limited resources and try and figure out, is gluten-free bread better than gluten-full bread? Is red wine better than white wine? Do we go deeper with what we have? Or do we take a step back and say, let's not leave some of these other populations in the dust, right? Let's make sure to leave nobody behind. Let's not go deep, let's go wide. Let's include more people of other cohorts. Let's get other populations in. There's no right or wrong answer. It's a strategy. I value your feedback and opinion. And on our end, it's one of the things we always have to contend with. Most people have only been recently diagnosed. Okay, this is where it starts getting exciting. Okay, so what I wanted to know is, how do you think you're all doing? When we just ask patients, in the last 6 months, do you believe your condition has gotten better, gotten worse, or stayed the same? Um, we have 4 times more people saying it's gotten worse than getting better. We have people saying it's getting better. It's about 7 or 8%. But this is what we're talking about, and this is where it starts to get good. And when I see that getting better, getting worse line, this is what I see in my head. I see a teeter-totter where the people who are getting worse are in the game of tug of war, they're winning. Right? This team exists. It's here. Like, I just want to figure out, what do we need to do to get more people on this team? But that's how I interpret this. I do want you to tap into your inner competitiveness, right? I want you to see this and see this as not acceptable. And I want to say thank you to those who are on this team, on this side, whether it's good luck, whether it is practice, whether it's discipline, whether it's skipping the ice cream at night, like you are single-handedly, you 300 people are giving me the momentum and juice to keep going because I believe something here is clearly working. There is a cohort of positive deviants for us to study, right? If nobody was in this cohort, this would all be dead in the water. The fact that these 300 people exist tell us keep going, we're getting closer. I'm getting better. That's getting worse. I was like, let's just get it together, everybody. Um, so this was me just trying to tell people who weren't familiar with the Pro-PD scale that it is in fact a legitimate scale. It has been validated. For those of you who don't know, I built the Pro-PD as an outcome measure for this study in 2012. And at a Parkinson conference in Sweden, the Swedish group asked me if they could start using it in their government-funded studies. And I said, sure. And so what they did is for 3 consecutive years, they took every fourth person, they lined up everyone with Parkinson's in the country of Sweden, and every fourth person was invited to participate in a study. They brought these people in every 6 months for 3 years and gave them all of the finger tapping tests, all of these non-motor tests, stand up and go tests, and they also gave them the Pro-PD. And what they said was that the Pro-PD is in fact a reliable and valid measure for monitoring Parkinson's symptoms in a sample of Parkinson's outpatient. So, Libby, can you make sure everyone's muted? Um, so this was kind of okay, now that a group that's not me has independently said, hey, this Pro-PD scale works, it's legit, it's valid, it meets our statistical criteria for validation. Now we can start getting to work on what all this stuff means. This is the rate of progression. These thicker dark lines here, you can see when the surveys were sent out. So we send a survey out. These are a wave of responses and some stragglers over the next 6 months, a wave of responses and stragglers. But that's what we're seeing here. Again, I'll just point out, we want to tell you what happens down the road, but until more late stage people start to participate, we're kind of guessing at this. We have always known, every patient with Parkinson's knows Parkinson's fluctuates over the day, over the week. This shows that it fluctuates over the years. People make different decisions, it goes up and down, all kinds of things happen to people. And I think this has been really one of the problems that we in this community have had. Finding a way to slow Parkinson's progression is because it's not clean. It's messy. It's really, really messy. The progression is not linear. And our statistician said, well, hey, if you take all these lines and you smooth them out, here's what it looks like. And, it's a little cleaner. You can see some trends, but I told her Parkinson's isn't linear. There's nothing about this that's linear. People change their behaviors, they change their attitudes, they change their stress level. And so she started playing around with different curves. The one that you have in your book, I started right around here. I started putting, for those of you who are following along in your handout, I put, or want to do it later, the page in the MVP study. There's an echo here. I'm not sure why. The page in the MVP study is listed over here, but what you all got is the non-linear smooth curve that we shared with you was neat, and I was actually really happy to see tremor. We'll talk about tremor in a minute. But when I was talking to my statistician, I realized she gave us the data from the time a person joins the study until they're no longer in the study. And so we can see we have a whole bunch of people giving us about 6 years of data. What I told her was actually more valuable to us is the journey of what happens to your symptoms from the day of diagnosis. And that's fun. That's where we can get 33 years of data, because over the last 6 years, there are people who have only been in the study between year 27 and 33, right? And so by putting all of the study participants together, we can kind of look at what does the story of each of these symptoms look like over time. And again, I mean, for me, you can see how I would really like to find a way to use handwriting as a way to be a better Parkinson's measure. That is the one that is changing most robustly. I'm very interested in, some of these ones that are spiking early in the disease. Dyskinesia, it looks like people are having quite a bit of trouble with early on, and then it evens out. They kind of, whatever is happening here, better med management. And the part that I personally find the most exciting is the lack of spike that you see in tremor. Everyone knows that tremor is the cardinal symptom of Parkinson's. This is what gets all of the attention. This is what everybody's trying to hide. This is what makes people self-conscious. This is what all the pharmaceutical drugs are targeting. And part of the success of this flat line may be related to the meds work so well to control the tremor that this is not one of the symptoms we need to worry about. But I do, for all of you who worry about your tremor, are distracted by your tremor, this slide is for you. Of all of the symptoms that exist in Parkinson's disease, the one that we don't actually have to worry about getting worse over time is tremor. Nausea doesn't get worse over time because people stop being nauseous after their body gets used to levodopa. And of all the other symptoms, tremor is the only one that doesn't get worse as disease gets worse. So I know it's a distraction, but it's really, I mean, I don't want to call it benign. That seems like I'm making light of something that is very bothersome to many of you. But my job is to make sure your Parkinson's symptoms don't take you down over time. Tremor is the symptom I'm least concerned about from a quality of life perspective. We'll talk more about that in a sec. Um, so these are kind of the straight and flattened lines, looked at it from a slightly different angle. This is my version of Where's Waldo for all of you to play with. You can just step back and see that the trend is to get worse over time. Most of these lines slope up. But it doesn't take long to start playing this little game. How many lines can you find that get better over time? 1, 2, 3, 4, 5, 6, 7. I mean, there are lots of people in here. And I'm using this to show you these are little needles in the haystack that represent some of you in this room right now. These are the positive deviants. They do exist. There are people who are figuring this out, whether it's with meds or exercise or diet or sleep or DBS or whatever they're doing. We have a whole bunch of people, a couple hundred, who are reporting improvement, not worsening. We've gone back and forth about who does worse, men or women. Initially, it was looking like guys were progressing slower than women. More recently, it's looking like now that with the bigger data set, looks like women might be progressing a little bit faster than men. It's not much, but we have been looking at these data over and over, and it does look like women are at a slight disadvantage. We don't know why. Does it have something to do with estrogen? Does it have something to do with us not going to the doctor, not getting the attention or the better drugs? We don't know. I hope to figure that out. I'd be very supportive of a male versus female competition. If you guys want to kind of join teams, we can see who can be the first team to reduce rate of Parkinson's. So the PRO-PD scale, as it currently exists, studies both motor and non-motor symptoms. Remember, we are not talking about what percentage of Parkinson's symptoms are non-motor. We are talking about the PRO-PD measures 2/3 of what the PRO-PD is measuring appears to be non-motor stuff. We are getting both motor, we are getting both non-motor. This is really more of a function of the scale that we're using and the way we're using it. It's not a function of your symptoms in your story. But I do want to let you know that if you are relying on the PRO-PD as your primary tracking tool, what that is 2/3 non-motor, and that's consistent as the disease progresses. It's not more non-motor symptoms early and more motor symptoms at the end. It tends to be about 2/3 of what we're measuring here are the non-motor things. Dementia, fatigue, sleep problems, erectile dysfunction, drooling, that kind of stuff. There's a really, really well done, validated measure of non-motor symptom severity. It's called a non-motor symptom score, NMSS. It was developed by my friend and colleague Ray Chaudhry. And what we did is we took his tried and true validated non-motor symptom scale and we just asked, if we just asked you all to, slide your bars, what we see is you are pretty much equally able to rate your own Parkinson's symptom as well as the validated measure, right? And so again, just more ways of backing up what we're seeing. When you ask a neurologist what is Parkinson's, they tend to say rigidity, slowness, tremor, stooped posture. When we ask people with Parkinson's what their symptoms are, this is the answer you get. This is what I showed you in the booklet. I made it a little different over here so you could see, but the symptoms that 80 to 85% of you have are fatigue, impaired handwriting, typing, and loss of smell. Then we get into the memory stuff, muscle pain, fatigue, slowness, tremor, sexual dysfunction, balance, urinary, hunched posture. So you can see as the symptom becomes more rare, it goes up towards the top. But I think it's just kind of a helpful paradigm to realize all of you know that your symptoms are so much more than the four cardinal motor symptoms. But this just gives it a different amount of weight to kind of take all of your symptoms together and put them in a bucket and say, really, what are most of you suffering with the most? And it's the fatigue, the cognition, the pain, that kind of stuff. If we're going in order through the book, this is on page 24. It is probably my favorite graph in the entire booklet, but it's the one that is out of order. And so we are going to talk about it, but we're going to come back to it in a second. But we're in the next page on we're going to talk about how to read these graphs. And so what we're looking at are correlation plots. How well do any two symptoms go together? So this darker the square, the higher they correlate. So if we take nausea and we follow the nausea line, here's a dark line. So it looks like people who are nauseous are also reporting a lot of medication side effects. Interesting. People who are reporting a lot of medication side effects are also reporting a lot of dyskinesia. Well, no wonder, of course, because nausea and dyskinesia are medication side effects. Essentially, three questions are essentially measuring the same thing. If I had been smarter 6 years ago, I probably wouldn't even put all three of those in there, right? I would have probably just used medication side effects in parentheses, for example, nausea and dyskinesia. And so that's what we're talking about is how well do any of these symptoms go together? So these are the graphs that I think are the most fun to play with. So for instance, let's take balance. Let's just look at the balance symptoms here. And you can see there are some that are clearly darker than others. So people who have balance problems also have more slowness, more walking problems, freezing, falling, dressing, eating, grooming. You can see that these motor symptoms all kind of go together. And that's not really surprising that people who have freezing of gait are having gait problems and more falls. Like none of this is really surprising. I'm just showing you how to read these charts. So who falls? Let's look at people who fall. Oh, look, they have bad balance. Of course, this is all quite logical, but then it can start getting fun. Well, what about people who lack motivation? What do we know about people who lack motivation, right? They are more depressed, more apathy, more fatigue, and more sleepiness, right? And this is where we can really start to understand how some of these symptoms go together. And we should be having conversations. Is it cause or is it effect? If effect, are you are you not motivated because of the depression and fatigue? Or, you know what I mean? Or if we just give you a medicine that helps your fatigue and your depression, would you be out calling your friends for lunch more often? Right? Can we fix one and see the other improve or do that? So this is where it starts to turn into something fun. People who are complaining about comprehension are actually have more apathy. Smell, right above it, smell is not correlated with anything. It doesn't matter how bad your sense of smell is, it isn't correlated with you doing worse. It could mean that smell is completely unrelated to this other stuff, and it's just a side effect symptom you have that's not related to anything. Or what's probably more likely is your sense of smell is so terrible that you don't know how to rate it. Bad is bad, right? Like, of all the things that you can give me a granular number for, that is probably the one that you are least accurately rating yourself, because I'm asking people who can't smell to tell me how well they smell. And so it could be that for that one symptom, this is not a good way to ask the question. But either way, for those of you with a bad sense of smell, this certainly doesn't look like your other symptoms are going to be affected, is what we're seeing here. So now we get into kind of some summary pages, putting it all together. You've all heard me say, and you've seen these charts for years, as your pro-PD symptoms go up, your quality of life gets worse. And these lines are not always easy to kind of figure out the where, like at what point do different people have different problems. But if we're going to call this a summary, this is what it looks like. This is the cheap, simple, easy scale. 0 to 500, excellent. 500 to 750, very good. 750 to 1,000, good. 1,000 and up, we start going downhill. And that is based on these increments. And it's just a crude, easy, simple way for you to keep tabs on how you're doing. I want all of you to have it as your personal goal that a score of 1,000 or lower on your 100th birthday. I want every day of the rest of your life to fall under the excellent, very good, or good category. That should be everyone's goal. Can I make it to 100 years old without my score going above 1,000? In the Swedish study, they did a very valuable statistic. It's called the MCSC, the minimally clinically significant change. And what they found is it takes 119 points for a person to, if you get 119 points worse, that's enough for you to say things feel bad. Things feel worse. If you have a 119-point improvement the other direction, that is enough for the patient to be able to say, I can feel things getting better. We can measure it in other places, in other ways, in other domains. So the Swedish rate of progression is a little steeper than the people in this study. And so I'm rounding and calling 119 100. But I think for those of you watching this and moving forward, what we are looking for is a 100-point change. If it goes up more than 100 points, you should call your doc. The average person goes up 50 points per year. If you have a 150-point bump, something's not right. Let's figure it out. And similarly, if your score goes down 100 points, awesome. Take yourself out, have a pat on the back. We're really getting somewhere. This is meaningful. This translates to other things in your life. This is hard to read. I wish this had been presented as a percentage instead of a count, because it's hard to see the ratios. For me, what I do is I focus on who's improving. And you can see there aren't that many 30 to 40-year-olds with Parkinson's, right? If we get into the 40 and 50-year-olds, I'm not that impressed. The 40 to 50-year-olds have just as many people getting worse as they have staying stable. That's not great. But they start to shine as they get older. As we get older, more people stay stable compared to the number of people worsening. And it's the folks in their 50s, 60s that really start figuring out ways to start to make things better. So that's kind of neat to see how that changes. We don't have anybody over the age of 80 who is currently making things better. So let's find them and enroll them. Basically, all we're saying here is quality of life isn't just one thing. We ask not just how is your quality of life, but how is your mental health, your social health, your sexual health, your financial health, your physical capacity. And what we are saying is, as all of those things get worse, pro-PD scores go up. So when I say it's associated with quality of life, it's not just one domain, it's a bunch of stuff. Things that are bad, just black and white bad. big picture, we can see that the people who say true to the following statements are clearly doing worse than the others. People who have a difficulty affording food, any food, healthy food, people who are lonely, have a lot of stress, and who are overweight. We can see those people clearly doing worse. So we are working to try and figure out why and what we can do about it. If we take these people and drop a $50 bucket of fresh fruits and vegetables and legumes and farro on their doorstep once a week, would we see them start to get better? Is this just a function of stress and poverty and inability to afford other things? Or is it truly a lack of food and fresh fruits and vegetables that is contributing to progression? We don't know. People who are lonely do not have a faster rate of progression. If you see, the slope lines are about equal. Lonely people do not progress faster than non-lonely people. They are just worse every step of the way. They are progressing at the same rate. They are just 55% more miserable along the journey. People who say, I have a lot of friends, are 21% less symptomatic than people who say, I do not have a lot of friends. If I said, hey guys, there's a new medicine out, it has no side effects, it's free, and it reduces your symptoms by 20%, most of you would jump on it. Right? So my suggestion is find yourself some new friends. We can see the outer bolus are the symptom severity of lonely people, whereas the inner bolus is the symptom severity of non-lonely people. You can see that where that extra 55% symptoms comes from. Everything is worse. Their handwriting is worse. Their sense of smell is worse. Constipation is worse. Every single symptom is worse in lonely people than non-lonely. Is it that those symptoms are really that worse, or is it that people who are lonely just perceive everything as being bigger, scarier, more severe, more frustrating? Is it a perception problem or an actual symptom problem? I don't know. And again, cause and effect. We can see not only which symptoms are worse, memory, apathy, motivation, depression, anxiety, sleep, fatigue, sexual dysfunction. I don't know what's cause and effect. I mean, I can assume that somebody who's tired and lacks motivation wouldn't call their friends for lunch, right? It could just be that those symptoms are causing the loneliness, or it could be that loneliness is actually causing some of these symptoms, right? So this is the future research. A couple months ago, we did gratitude talk for Thanksgiving. So you've already seen this chart, but I showed that just being thankful, people who are just walking around appreciative are less symptomatic than people who aren't walking around expressing gratitude. So it's a big surprise to me that being single was such a risk factor for quality of life issues. When we take poor people who say my quality of life is poor, there is a 50-50 chance that they are single or married. As quality of life improves, among people who say my quality of life is excellent, 89% of them are partnered, only 9% of them are single. It is so, when I started this study, I never crossed my mind that being single was a risk factor for Parkinson's severity. I mean, it makes sense that a single person who is lonely and isolated and having, that makes sense to me. But I would like to believe that a single person is just as likely as a partnered person to have an excellent quality of life. Is that financial? Is that support? Is it, getting annoyed at your partner for moving things is enough to keep the blood pressure a little higher and that keeps you a little healthier? I mean, I don't know what this is, but there are a lot of single people, and many of you will find yourself single one day if you're not already. And I think that we need to give some thought to the why behind this. Kind of tying it all together, again, you can see when we looked at people's quality of life, poor, excellent, quality of life goes up as this number increases. When we look at people's tremor, whether they said, I have a horrible tremor or I hardly have any tremor did not matter much in terms of quality of life. It has very little bearing on one's quality of life. What has tremendous bearing on quality of life are people who are lonely and people who have a lot of friends. Like, really, tremor means virtually nothing in the grand scheme of things. Every time you're worried about your tremor, stop yourself and say, "What new friend have I made this week?" Right? Like, let's control what we can control and put our money where it matters, right? Like, this is where the fish are biting. And it sounds hokey from, like, a biology-based perspective, like, come on, like, all this stuff we're doing, you're gonna tell me friends are part of the solution? And I don't know if it is or it isn't, but I again, back to AA, I honestly believe that AA has been a more successful solution for alcoholics than any pill or procedure the doctors have come up with. And if we break down why is AA successful, the community is very much a part of that medicine. The coming together of a community. There is actually a medicinal value in coming together as a community, a tribe of people, whether it's support, whether it's a network, whether it's a boost of you can do it, a cheerleader. I don't know why, but I do think that there are other diseases where there are examples that we can follow of community being part of the package. Here we can see that people who are lonely, being lonely is worse for you than 7 days a week of exercise is good for you. Like, that's how much it matters. For all of you who are tearing yourself off the couch every day to go break a sweat and get a workout in, imagine all the effort and work you do for 7 days a week of exercise if you're still coming home feeling a sense of isolation. It's all for naught, right? They just canceled each other out. So, this is why I'm steering people more. Yes, I want you exercising on your treadmill, on your bike, going for walks around your block, but it is so easy to find some way to plug into an exercise group with other people. Online, pickleball, table tennis, badminton, Zumba. But I do think leaving the comfort of your home and going to a class where other people are engaging and you slowly start meeting and making some new friends is a good way to feed two birds with the same seed. If you are exercising with friends, you can make all of this go away. Um, Loneliness is a really loaded subject. And I actually think we ask people, true or false, I am lonely. And I think it takes people a long time to even acknowledge loneliness. I mean, I think if you've been isolated for a long time, you sometimes don't know what you don't know. You don't even realize what you're missing out on. And you just start finding it normalizing isolation. And so the UCLA researchers have come up with a list of questions that help identify lonely people. And all of these, you can see the more somebody answers affirmative, the more lonely they are, and they all work. But the single question that had the biggest spread is I feel left out in Parkinson's patients. If you just ask patients, do you sometimes feel left out? That is the single question that is most likely to identify a person who feels lonely. And it's interesting because I was thinking myself, like, I don't identify as lonely, but I do sometimes feel left out. Right. And you start thinking, okay, you break that down like, okay, as a single person, as a this and that, where does that come from? And so I just want you all to acknowledge the spectrum that loneliness is not black and white. You can have a partner you love the heck out of. And if they don't understand what you're going through, you still feel lonely. Right. So loneliness does not mean I don't have people around me that I love. There are three different types of loneliness, right? There is, do I have somebody who understands my soul? We don't need words. They can look at my face and know what I'm feeling, right? There is the hustle and bustle of a house, housemates and people running in your space and moving your coffee cup and how's your day and just chit chat and they know what's going on in your life, on a routine level. And then there's your tribe, like if you're a veteran or you're Jewish or you participate in the same chapel every weekend, right? Like you find your third place, they call it, like this place outside of home where people know you. You're all there to salsa and we all love salsa and that's what brings us all together. We're a salsa club. So it's this third place where people feel a sense of belonging. So anyway, I think there's a lot of room to break that down a little bit, especially given how severely it is impacting it is associated with Parkinson's. The exercise thing is pretty interesting. I'm going to show this slide from a couple different angles. What this basically says is the more exercise a person does, the fewer symptoms they have over time. More is better. And the first 2 days a week don't really count. Not only if the black line crosses the center, it means it wasn't statistically significant. And I just showed you on one of the other slides, it takes 100 points, 119 points for it to be meaningful. So you can see even people who are doing 3 days a week of exercise are reaching that point where we can meaningfully measure enough improvement that we can see it affecting other parts of their life better. So the 100 point is where we start saying, all right, this might be really doing something. So you can see how easy it is to get there, even with 3 days a week. We looked at this is old data. We haven't done this recently. This was for Movement Disorder Congress 6 years ago, but we looked at um, different types of exercise, whether runners who were breaking a sweat and getting their heart rate up might be reversing their symptoms more than people who are doing a more quiet or, yoga. And so we looked at people who exercise 0 to 1 day a week. This is the number of them that are getting better, the slice of the pie. These are daily exercisers, 6 to 7 days a week. We have not 12% of them getting better. Among the runners, 8% of them are getting better. And the yogis, 15.3% of all the groups that we studied back whenever we did this, the people who say, I do yoga, even if it wasn't every day, were the cohort of people reporting the most improvement. And I like this because I think there's this tendency to more is better. It's not real exercise if you're not dripping with sweat and breaking your heart rate, getting your heart rate up and 80 to 90 rotations per minute and all these things that we do. And I have said to all of you 10,000 times, yoga, 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 yoga. It is balance. It is resistance training. It is just outside your comfort zone. When people, even people who fall more gracefully and are less likely to break a hip because their bodies are more comfortable in uncomfortable positions. It counts as mindfulness. Your meditation is involved. In my mind, yoga is as close to one-stop shopping as we're going to get, except you do need the something in your life that is also community. But this is just my um, trying to steer you all towards yoga. This is another way of looking at the exercise data, and you can see how scores decrease as one's days of exercise increases. And there are some people who are exercising every day and still doing really poorly. They're unusual, they're outliers, but they exist. There are some people who don't exercise at all, and they're actually doing quite well. But if we just take a step back, you can see that there's something that happens around 3 or 4 days a week where symptoms do actually seem to be getting better. It doesn't matter how many years you've been diagnosed. We can see the people who exercise the most have fewer symptoms. Okay. This is just so that you can, for me, a wake up call. It's time to add a checkbox that says, are you boxing? Because, like I can see how trends in the community are changing. And I want you to all see how hard it is to study this. I mean, if we were to study what form of exercise is best, do we put boxercise in the same category as boxing? Do we do boxing lessons and boxing training? Is that the same as going to Rock Steady Boxing? And so you can just kind of see when we give you these fill in the blank sections, it's really kind of exciting for us to see like just free flow, what you guys come up with, but it's really a nightmare to study it. We actually have to have a grad student whose entire job for a year is just to figure out how to categorize these and what does it all mean. Getting into supplements, we've been through this a lot of times in the past. There have been 2 publications now on supplements associated with different rates of progression. I don't think we're going to get into a big supplement conversation here, but I want to point out a couple things. I very intentionally included this because iron has been in and out. Like the next page, iron is not statistically associated with worse outcomes, but the last time it was, and if you just look at this year alone, 2024, iron is back on the bad list. And so the reason I needed to include that is because many of you have high iron. One of my concerns is that many of you are getting more iron than you need. When we get to the bread and pasta section, I think my personal opinion is it's not the gluten that is causing problems like many of you think. It is the iron fortification that we are adding to your bread and your pasta and your flour that are causing a problem. Because if iron is truly associated with worse Parkinson's outcomes, and every grain and bread and pasta that you buy in the United States is fortified with iron, you are essentially taking an iron supplement every time you eat a piece of bread or have a bowl of pasta. And that might explain why we're seeing so much more progression associated with bread and pasta and not farro, millet, and quinoa, right? So little things like that that I just want us to start being on the lookout for. Interestingly enough, the supplements that are being used most commonly are not the same as the supplements that are working best. That's fine. Well, we've talked about that in the past. I've said over and over, I don't think this is a shopping list. I don't think you all need to start taking all of these supplements. But for those of you who weren't here in the past and just want to know how to read this, what we did is we asked 1,100 people in the last 6 months, which supplements have you taken consistently? There were 19 people who are taking ginkgo. Those 19 people are on average 357 points less symptomatic than the average person not taking ginkgo. And when we look at those 9 people, their real true answers were anywhere between knocking it out of the park and still doing, minus 100. So this is our confidence, and this is the average. And so what this is saying is this is statistically significant and it's clinically relevant. But now you and I have to make a decision and say, listen, I get it. I get that the 19 ginkgo takers look like they're doing really, really well. However, those 19 people might be doing a lot of other stuff too. It's only 19 people. They might be eating their vegetables and going to bed early and on all the best meds and taking all these other supplements and eating the right diet. And so even though the ginkgo people are in first place and knocking it out of the park, there's part of me who thinks, come on, is 19 people really enough for me to ask all of you to start taking ginkgo now? There's never once been a human study where we give ginkgo to people with Parkinson's. There are 100 studies that say, oh, wow, in the test tube, there are 100 different molecules inside the ginkgo plant that might be useful in Parkinson's, but we have never, ever once done a Parkinson's ginkgo study. And here it's coming in first place. So I have patients who say, listen, money is no issue. I don't mind taking pills. It's $17 a month. It's one pill a day. People have been using ginkgo for 3,000 years to improve brain. Like, bring it on. There are other people who are saying, are you kidding me? Like, I've got pills coming out my ears. There is like, I don't want to spend any more money. I don't want my pill bottle to be any higher, bigger than it already is. You want me to start taking a supplement that has never been studied in Parkinson's patients before? No. Like, pick and choose your battles. I'll take 3 or 4 of the ones that you consider most important, not all this other stuff. And so this is what we do in clinic, is kind of help you figure out, which of these meet your value system, fit in your price tag, where we start having hundreds of people taking glutathione, CoQ10, low dose lithium, turmeric and curcumin, homocysteine factors, where there's more than 100 people and it's still statistically significant, that's kind of easy for me. The data is starting to be strong. 10% of you are using it and it's consistently showing up to be associated with benefit. That's where I start saying, all right, so that's kind of how I've used my cutoff, the ones greater than 100. Vitamin C, fish oil, coconut oil, DHEA, I measure in all of you, the B vitamins, stuff that we've been talking about for years now, but that's how you read this chart. Melatonin made me a little bit nervous. Melatonin, so many of you take melatonin, and our data said people who take melatonin do worse over time. That freaked me out a little bit, and we kind of thought it through and we realized, well, the only people who take melatonin have bad sleep, and bad sleep is already associated with worse progression. And so what we did is we plotted people's bad sleep against Parkinson's severity. And what we see are that the melatonin users actually have a slower rate of progression. So among people who get bad sleep, melatonin seems to be a good thing. So melatonin looks like a bad thing until you realize it's not the melatonin, it's the bad sleep that causes them to need melatonin appears to be what we're seeing. I slipped this one in to page 49. Again, I wanted the iron to be on there as bad. And this is the only place in the entire booklet or any of my publications I've never published that rasagiline is associated with slower Parkinson's progression. I've talked to you about the foods, I've talked to you about supplements, I've talked to you about exercise. We've not really cracked pharmaceuticals. And the reason for that is because a lot of them actually look like they're associated with worse outcomes. And I don't want to freak you all out because the people who need to move on to use some of these other drugs are doing poorly. And so I'll just tell you that in the toolbox of dopamine meds that you all have available to you, the only one that is statistically associated with slower Parkinson's progression over time is rasagiline. And for those of you who are thinking, well, why aren't I on this? Should I run out and start it? Should I start rasagiline? Look at this number 158. So I just want to show you 158 is about as helpful as coconut oil in your diet. 158 is less effective than your B vitamins. So it doesn't mean it's not useful, but in terms of trying to answer the question, how helpful is it? Yes, I get that rasagiline is associated with better scores. It's about in the ballpark of B vitamins, coconut oil, vitamins, that's the degree of the impact. This is pretty exciting, and I wish more people saw this, knew this. We will publish this formally. We need to fix a couple things here. But what we did is we took people who had never, ever, ever touched levodopa, who had a diagnosis of Parkinson's, and we rated their symptoms. And then what we did is we asked those same people who went from not on levodopa to 3 pills a day of levodopa 6 months later what their symptoms were. And all of the symptoms under blue are the ones that got better. Nothing got worse, but the symptoms that improved the most were anxiety, muscle pain, sleep, apathy, balance, fatigue, tremor. We think of levodopa as a motor drug. And I'm here to tell you there are a lot of non-motor things that get better when somebody starts dopamine. And for all of you who are out there possibly struggling, if a person with dopamine, I don't care if you've had Parkinson's 10 years, if you come to me and say, I have anxiety, muscle pain, sleep problems, and apathy, the first question I'm going to ask is, are you sure you're on enough meds? I need you all to hear, believe loud and clear, anxiety is a symptom of low dopamine. Truly, it is one of the tricks I have up my sleeve. So we can talk later about that. Same thing with DBS. We can see that DBS improves symptoms, specifically tremor, insomnia, dyskinesia. What is interesting, and this is really great for, I think, all of you with DBS, is it seems to be getting better over time. At 6 months, we can see some improvements. 12 months, we can see even more improvements. And there's another slide of 24 months, and it's even better. And so it's kind of neat for people to realize that the results you get when you walk out of DBS are just the beginning, that your brain will actually work with the DBS system and continue to see improvements over the next couple of years. So that's pretty exciting. Unexpectedly, we saw some adverse effects from DBS. I think there were only about 60 people in the study who had DBS. And so we don't have the ability to look to see if people who have, there are 2 different types of DBS, STN, GPI. We don't have enough people yet to see if one type of DBS is better or worse than another. But what we can see is 6 to 12 months after deep brain stimulation surgery, people were complaining of more sexual dysfunction, worse sense of smell, more speech problems, urinary problems, and comprehension problems. So this is just one study. I called one of my friends, runs a DBS center, and I asked him about these sexual side effects were surprising to me. And I said, is that something that you've seen at your DBS center? And he said, to be completely honest, I don't know anyone who's ever asked. We've never asked at our facility. I don't know any other doctor who's ever looked at sexual symptoms before and after DBS. We've just never even thought to go there. So, whether or not this is a one-off in this cohort or this is a new side effect of DBS that we're uncovering, I don't know. But as more of you join this study, we'll be able to look at that a little further. This is just a little visual break from all the data. This is food. Um, Quite simply, the people who are doing the worst, I've already said this, have trouble affording groceries, are overweight, they drink from plastic bottles. The people who are doing best eat organically grown foods when possible, buy locally grown, they buy from co-ops, farmers markets, they cook a lot for themselves and they cook for others. This might be function, but it also could be avoiding the additives that you get when you go out. You can all look at these charts later. The numbers that are negative mean good. Anything that goes to the negative is associated with better outcomes over time. All the things that go positive are associated with worse outcomes over time. It's the same information we've just talked about, just conveyed differently. This is fascinating. This is really hard to read. I don't expect anyone to kind of spend too much time on this, but what I want to show you is, say this blue one, 7 is a serving size of it's like maybe 2 to 4 servings a week. So when we look at people who are blue, the people who we'll go up to green. We'll just say 6 is a moderate consumption of beef. So this teal one is what we'll use. So for people with the fastest progressing Parkinson's disease, they are eating beef this often. For people with the slowest Parkinson's progression, they are eating beef this often. It's just a little bit less. And so, what I'm trying to show you here is that I don't think you need to, the data does not suggest that the purists are doing the best. Right? Like we see when we study these people, there were 400 people who are truly not progressing like the rest of the folks. And what we see is they aren't purists. We can see when you look at the fresh vegetables, right? Like look at fresh vegetables. Like in terms of frequency, the fresh vegetable eaters are eating a lot, are more likely to have like daily consumption. Like you can see a little bit of an uptick on some of these, but it's not much. It's not much. And so the point of this slide is really to let you know this is messy, that I truly, truly, truly believe that you don't need this concept of never ever cheating. I don't know that that's helpful. I think we want patterns. We want to associate with a type of person and a type of diet. But I truly, looking at these data, interpret this as, wow, like you don't need to be a purist. Like fresh fruit, the people with the slowest progression have a much higher spike. They're eating a lot more fresh fruit compared to, you don't get that same spike on fresh fruit. Fresh fruit is not as high in the people with fast progression. That difference is where we're seeing the rubber meet the road. So it's a little confusing, but the point here is it's not absolutes that are shaping this, it's all adding up over time. The mind diet is basically, we'll talk about what the mind diet is in a second on the next slide, but what we can see clear as day, the more any person adheres to the mind diet, the less constipation, apathy, depression, anxiety, insomnia, muscle pain, cognitive, sexual, and urinary dysfunction a person has. I mean, if I asked you all, raise your hand if you have one of these things that you would like to get better, most of you would raise your hands, right? Like, let's make sure we are adhering to this diet. So the MIND diet is the stuff that you see in this circle. The Mediterranean diet is the stuff that you see in this circle. The stuff that is actually good for Parkinson's disease is in the square. So there are parts of the Mediterranean diet that really don't seem to be driving the Parkinson's stuff, right? Like fruit and fruit's good, olive oil's good, legumes are good, but that's not what makes the Mediterranean diet awesome for Parkinson's. Where the real points mattered were avoiding carbonated beverages, avoiding red meat and pork, and encouraging nuts, fish, and vegetables. That was the part of the Mediterranean diet that made the biggest difference. The MIND diet actually would have been stronger if it didn't include poultry. If the MIND diet was without poultry, it would have been an even better diet for Parkinson's disease. Wine, whole grains, olive oil are part of the MIND diet. They don't seem to be shaping the Parkinson's story. It's this stuff that is shaping the Parkinson's story. The green leafy vegetables, the beans, lentils, soybeans, non-fried fish, berries, avoiding the pastries, sweets, fast food, cheese, beef, pork, in eating these things. So again, many of us saying a lot of the same thing. And that's all this slide is showing is, I think most of you on this call today are probably already on board with the diet to some degree. But for those of you who may be kicking and screaming or have family members who haven't quite gotten on board, my advice is just start with the stuff that's easy that we all agree on. I mean, it is so easy to have an apple and peanut butter, right, as a snack, nuts and seeds, fruits and vegetables, fruits. No one's disagreeing that that's healthy. More vegetables, more stir fries, more veggie trays when you're waiting for the meal. Just find little things on the green list that are kind of universally, we all seem to be saying the same thing. It doesn't matter if it's my research, mind research, medi research, keto research. We're all saying this is good and this stuff is bad. So we can, for those holdouts who want to kick and scream about poultry and dairy and things like that, you can wait until that story is told. But please, please, please start on the things where there's universal agreement. This is where it starts getting also fun. I love these correlation plots. This is really, really what I care about. And the point I'm trying to say here is we're not really looking at food. We're looking at food patterns and people who eat these foods. So the blue stuff is stuff that goes together. So people who eat a lot of canned vegetables also eat a lot of canned fruit. People who drink a lot of milk also eat a lot of canned fruit. They drink a lot of soda. They drink diet soda. They drink from plastic containers. They drink more juice, and they actually don't drink enough as much green tea. And so what we are doing here is the same thing that we were doing on the other graph is, so we take fried foods and let's just follow it up. And on one hand, the scientist in me wants to study the fried food. What is it about a potato that once you fry it, it becomes a problem? Is it acrolein? Is it and free radicals? What is it? And what I'm here trying to tell you right now is it might have absolutely nothing to do with the fried food at all. It could be that there is a personality, there is a type of person who eats fried food. That the fried food eaters are a type of person who drinks juice. They drink from plastic bottles. They drink more soda. They eat more canned fruit. They eat more pork, chicken. They drink more milk. They don't actually eat much yogurt. They do eat a lot of cheese and butter and ice cream, and they're not having any olive oil and coconut oil. Right. And so now all of a sudden we start getting into like, oh, we're not talking about for the last 10 years, I've been telling all of you, hey, coconut oil is the people who eat coconut oil is good. So go eat coconut oil. I am now not convinced if we follow this out, if we look at the coconut oil eaters, same thing, the darker the line, the less they do these things, right? So let's follow up the coconut oil and find the lines that are dark. These people don't eat canned fruit, they don't eat cheese, they don't eat milk, They don't eat ice cream. Look for all the black stuff. They don't eat fried food, soda. They coconut oil eaters don't eat bread. Coconut oil eaters don't eat pasta. They're not eating safflower oil or drinking juice or drinking from plastic bottles, are their darkest lines. So all of a sudden, I'm wondering how many wasted teaspoons of coconut oil I've made you all eat over the years. I don't know that coconut oil is good for you at all. But I can tell you, coconut oil eaters have something figured out. Maybe what they have figured out is they should eat coconut oil, but maybe what they have figured out is the stuff that they're not doing. Right. And I don't know which it is. And this is back, there's this, like in business, there's this saying like your your success or your income is the average of the 5 people you spend the most time with, right? It's that kind of a concept. Like, I don't know if it's the coconut oil or the stuff that the coconut oil eaters aren't doing, but my advice is you should just go hang out and be friends with the coconut oil eaters because they're doing something right. Right? Like until we figure out which it is, just do what they do. Okay? Because they're doing something right. They do eat a little beef and pork. This univariate analysis is frustrating and it's a teaser, and I need to let you know, like we really, truly, these numbers do change once we start adjusting for age and gender and income. It might be that the only people who eat from cans are poor people, and cans look bad, but once we compare poor people who eat cans and poor people who eat fresh, it actually doesn't matter that much. We weren't really seeing the can problem, we were seeing the poor problem, right? And so we really do have to start adjusting for different things for this to be useful. But what we are doing here is the clean, pure, unadjusted. The example they use is baking a cake. If we were to put all the ingredients out on the table, this is the equivalent of picking up the butter and being like, oh, I see how warm it is. I see the consistency. It's salted. It's not salted. Here's the flour. And we're just kind of looking at each individual variable before we get fancy with it. We just want to know, does this stuff link to Parkinson's? And this column here is my little cheat sheet. And for me, it meant a lot if it was consistent, right? Because, like some of these were not consistent. Black tea, in the past, the data has not shown black tea was bad. All of a sudden, our data here show that black tea is bad. Green tea is still good. That's not necessarily what we've seen over the past. I question those data. It might be true, it might not be, but it's not consistent. Fried food, every step of the way, we have seen fried food is bad. The more fried food you eat, the worse it is. That's what we mean by dose dependent. Pork is not dose dependent. Whether you have one serving a week or one serving a month, it doesn't seem to matter. It's just a little bit bad. So I was just trying to kind of create some organization in my head for how much do I trust these data. It kind of matches everything that we've been talking about for years.
She's she. This is
the
she's live. This is live from.
and somebody's unmuted who's talking about being live. Um, And the surprises were coffee is bad, eggs are bad, black tea is bad, were a surprise. We don't know that those are bad yet. Don't get all worked up about this yet. We have a little more work to do here. But that was a surprise that we have not seen in the past. And what was another huge surprise is how unbelievably good wine is. Wine is really good. I went to my statistician and I said, listen, we do not know much about Parkinson's, but we are very, very, very sure that people who drink coffee don't get as much Parkinson's. Coffee for 30 years has been shown the more coffee a person drinks, the less likely they are to get Parkinson's. For all of our other data makes sense, but for the first time, our data says that once diagnosed, the coffee drinkers seem to be doing worse. We can't figure out what that means. My statistician sent me all these fancy tables showing, oh no, look, you can see the impact of coffee intake. I can't read this graph. I don't know what this means, but she assures me that we are seeing a very measurable effect related to coffee. And she's kind of trying to figure out what that means, but it's a surprise to all of us. And we're looking at it from angles I didn't even know were possible to look at it, but it's a surprise to all of us. Um, Here we're back to kind of some of these situations that people find themselves in. And again, I want to say, like I told you earlier, people who are overweight are doing worse. They are progressing faster. It could be because adipose tissue is inflammatory. It could be that people who are overweight are not going to the gym and getting exercise. It could be that this has nothing to do with their weight, but people who are overweight are more likely to have difficulty affording groceries and healthy food and have a harder time cooking their own meals. They're less informed about what's on the dirty dozen, and they are not avoiding dairy and beef. So again, is overweight about the adipose fat tissue? Or are we talking about a type of person and a type of behaviors and a type of situation that overweight people commonly find themselves in? Same thing. Who has difficulty affording groceries, right? Like it's really like um cooking their own food. Anyway, this is designed to look at knowledge, education, and how they all come together. This is a summary slide of dietary behaviors that largely matches what I've been telling you over the years. People who, and this is the starting point. This is honestly kind of depressing. I mean, it makes it look like even all the good stuff you do, the good stuff only helps a little, the bad stuff can hurt a lot, is how I interpreted a lot of these graphs. People who have difficulty affording healthy food and groceries doing clearly worse, people who are overweight clearly worse, and the people who are doing better, as you might expect, use spices liberally. They say true to all the following statements. I use spices liberally. I try to eat organically grown foods when possible. I cook for others. I cook for myself. I buy local. I avoid soda, pork, dairy, beef, artificial sweeteners. I mean, this is what we've been talking about. I do think this is pretty low-hanging fruit, simple, universally consistent data, easy things that you can all start. Figuring out where future directions looks like is going to be difficult. I have a bunch of statisticians working right now to try and assign these points. If anyone's ever done TurboTax for their taxes, I kind of have this fantasy of you scroll your little dot over, oh yeah, I eat that 2 times a week. I do that 6 times a week. You tell us the frequency of consumption and or some sort of point scale where every time you do something right you get points and lose points. And once you answer your questions, I say, hey, based on the behavior that you're exhibiting this week, keep this up. This is what your trajectory will look like over the next 10 years. Oh, you keep that behavior up, this is what your trajectory is slated to look like over the next 10 years. We are almost at a point where we can start to calculate that. And that's going to start to be very, very empowering and exciting. And then lastly, I just want to say thank you. Thank you to the people who made this possible. This group, as there are a bunch of people on this call today who are on this list. And I just want to say this goes beyond the money that you have given. Your support, we have done this together. So thanks to those of you who have trusted me with your money and trusted in me to start to put this picture together. I think we're really getting somewhere. So thank you very much for the help. And I think we're truly just getting started. In the next 4 months, I predict in the next 2 months, we will turn in for publication papers on whether or not exercise intensity and how much exercise intensity is required to slow progression, what defines sexual health in Parkinson's disease, a breakdown of financial stability and what that means for people with Parkinson's, financial health and Parkinson's. We have a paper going in on the microbiome associated with Parkinson's disease. We have a paper going in on alcohol intake in Parkinson's. The more you drink, the better you do. It is driving me crazy. I want that to not be true. And we have a paper showing, I took a snapshot of patients from my clinical practice, and we are showing what I hope to be the first data I've ever seen that says you can actually watch people improve over time, not get worse. So that is 6 more papers that are going to be coming out of a lot of this work here in the next couple months. So this really, it was just a launch pad, a foundation to kind of what's to come. And things are officially, we've launched. This is real. This is respected. This is established. And I'm excited to see where we can go with it from here.